Welcome, everyone. We appreciate your patience with our technical challenges. As you know, this is the first time that we've done this, but we are having this town hall to talk about COVID-19 and connect with ourselves and with you and answer questions about where are we now and where are things going with coronavirus for us, and especially in the setting of liver and intestinal transplant. I was hoping that each of us could introduce ourselves so we can know who is on here. So each of our presenters. So I'm Rachel Bensen. I'm one of the liver transplant physicians. And maybe we can just go on around each of us to share who we are.
What order are you going in, Rachel? We all see different screens.
Got it. Well, maybe I'll just direct you in the order that I have it. So I have Dr. Narang is next.
I am Amrita Narang. I'm also one of the liver transplant hepatologists.
Dr. Gans, I have you next.
Hi, I'm Hayley Gans. I'm one of the physicians in the Pediatric Infectious Disease Division, and we collaborate with your liver transplant team.
Rachel Schwartz, I have you next.
I'm Rachel Schwartz. I'm one of the PAs on the outpatient liver transplant team.
And Dr. Chen.
Hi, my name's Sharon F Chan. I'm one of the pediatric infectious disease physicians.
And Kat.
I am one of the transplant coordinators.
And Noelle, Dr. Ebel, who I've stolen her computer because mine is not working.
Hi, Noelle Ebel, one of the transplant hepatologists.
Thank you. Kat, perhaps you can advance the slide.
Yes, I'm sorry, guys. Oh, we missed Denise.
Oh, sorry, that went. Denise.
Hi, I'm Denise Alloway. I'm one of the liver transplant social workers.
Did I miss anyone else? Okay. And just so all of you know, the way this is set up is that you can type questions in the Q&A and we'll do our best to keep an eye on those as we go. We had prepared some information for you as we received questions from folks over the past few weeks. And so we'll begin with sharing that information with you, and then we'll do our best to answer the questions in the Q&A towards the end or as we go along. And here on there, we have our goals, again, provide updates about what we know about COVID and address concerns and questions that have been coming up over the past few months, but in particular, the current state in the past few weeks. And then there's also a feature where you should be able to kind of highlight a question from someone else if you see it in the chat as saying that's a question that I share as well. That'll help kind of let us know that that's something that multiple folks are interested in seeing. We've already introduced ourselves. And so this is just briefly kind of going through what we're going to be talking about. So initially some updates about COVID-19 in pediatrics of where we are now, discuss things, considerations to keep in mind when we think about that challenging question of do we go back to school, work, daycare, or other activities? What do we know so far about outcomes for children who have had liver and intestinal transplant, and how are we collecting data and knowing about that at this time? What are we doing with medications? What is kind of the current state in our hospital and clinic and lab today? And then what are general ways that we can address the stress of coping with being at home, dealing with COVID, and what kind of resources are available to address that? So we'll start with our infectious disease team next.
Thank you, Rachel. Thank you for the organizers of this and Kat for putting this together for us. I want to welcome the families here. It's really nice to be spending this time with you, to be able to provide a forum for you to voice any concerns you have and any questions, and we'll do the best we can to answer them here today. So as a reminder, I'm an infectious disease specialist at Stanford, and with myself and Sharon Chen, we do run a program that actually works with all of our immunocompromised hosts, so children whose immune systems have been suppressed for some reason or other. So we work with your liver teams and trying to come up with the best way to care for all of our liver transplant, both candidates and recipients. I was going to just give you a real sort of high-level overview of the virus, because I think that sometimes it gets very confusing how much information there is out in the public realm. And also, I think it's very confusing to really understand the risks that it poses for you, particularly, and your child. So next slide. So I just want to remind everyone, we're here today talking about coronaviruses. The word corona actually means crown, and it was really named for these. You can see the picture that I have there of the virus, and it has these sort of projections that come out of it that looks like a crown. These are important proteins that are live on the surface of it, just how they enter the cell and enter the body. There are it's a very large virus, and it's very stable, and it's good to know that because it doesn't change quickly over time, unlike some of the other viruses we're used to hearing about every year. So influenza, where we have to get a vaccine every year for it. We don't know where this is going to go, but it is stable, just so you know that. There are 4 types of coronavirus. It's a huge family of viruses. There are 4 types that come around every year, and they have been infecting humans for very many years, and so we've become more adjusted to them, and they really cause the common cold. These come to us every year. Everyone gets infected with them, even gets infected with them over, and that's what we call the common cold. We also have had now 3 different of these coronaviruses that have sort of jumped from animal populations into human populations, which is how most viruses come to us, and they've caused more severe disease than that common cold. In 2003 was the first time that we saw this with something that you might be used to hearing called SARS. That was followed in 2012 by something that you might have heard called MERS. Both of those have really died out. They didn't cause a lot of spread of the disease worldwide. We don't really know why. And here we are today in 2019, where we have this 3rd virus that has jumped in that same family, causing slightly more severe disease than the common cold. Next slide, please. So I just want to talk a little bit about disease severity, because I think we hear much about the 2% of people who are infected by this, and I think it gives us a sort of different view of this virus. What we understand now, since at the beginning of this, remember this has only really been with us for about 4 months that we know of. There are reports of it being present and disease that looked like it before that time, but really March is when we've been mostly introduced to that in this country. There were some reports in other areas of the world earlier than that. So what we understand now is that 85% of people who are infected with this virus have no to mild symptoms. 15% will have a little bit more symptoms than just mild, not, you know, the mild symptoms are sort of, I feel a little under the weather, 13%. And then the severe disease is really in 2% of the population who gets infected with this. Next slide, please. And just to let you know that that actually percentage-wise actually shifts with age. And this is just the hospitalization rates with age. And I just want to point out that probably what you have heard is this isn't really a severe disease in children. So you see that on the left side of this graph are the number of children who get hospitalized. You can hardly see the bars. And there's a steep rise as you age. And so age is actually a really high predictor of risk for severity. You can see again, the 2 blue bars on the right-hand side, overall hospitalization rates. Most young people, if they do get hospitalized, and there can be severe disease in young, mostly in the sort of middle of this population, most of them get better and go home, whereas hospitalization in elderly age can be more chronic or lead to mortality. Next slide, please. So just to give you an overview, we know worldwide, that's a picture of the world map, 9 million cases so far. I don't know if you can see it because I can't very well, but the United States leads the pack with 2 million. That's followed by Brazil, and you see some other countries there. Next slide, please. I just want to give you a real high-level overview of the numbers. We talked about worldwide. The US, we said, was at about 2 million. I want to talk a little bit in this box that you can see on the top. We have tested 4 million individuals in the US, and of those, 216 are positive cases. That's a rate of about 5.5%. And hospitalizations is only in 2%, so that's 6,000. So it just gives you a sense of two things. 5% of the population has had COVID infection, so we're continue to be a very naive population. Most of us have not seen it. And 2% of those tested are sick enough to be hospitalized. And on the bottom, you just see trends that I wanted to point out. The graph on the left is just showing you the cases. And you can see that since it was introduced into our populations, obviously there's been a rise, although you could say it's pretty stable with a little bit dip in the middle. And then the good news is, as this has actually been with us for longer, we've actually gained an understanding of treatment. You can see on the right the graph where, despite the cases going up on the left, the death rates are going down on the right. So greater understanding of treatment and shift in age groups has given us this new state that we're in. Next slide, please. So I just wanted to point out that this is Santa Clara County. We've done pretty much the same thing that has happened globally. We did have a dip with our shelter in place, if you could see on that top graph, but overall, as we're opening up, as we expected, there's more cases. But as you can see on the bottom graph where the arrow is going down, that will show you the daily mortality rates, those who pass away from this. And you can see how it's becoming a less rare event. Next slide, please. And I did want to point out here that our population, because we were, California was the first to go into a shelter in place, is that we have now tested, this is Santa Clara County, but it really mimics what's happening mostly in our populations. We've tested about 133,000 people, and only about 2 to 3%, somewhere in the middle, is positive, a little lower than the rest of the country, as you saw, 5%. Next slide, please. So this is important to understand who, as we said, this is not a severe disease in children. And you can see, if you look at the infection rates, you see the population 18 to 34 and then up to 59. So between 18 and 59, if you look across, the most number of cases are in that age group. But if you look down at the population from 70 to 80 plus and shift over to the other blue box, you see that actually greater than 50% of the mortality is in that age group, not in the people who tend to be the higher populations in our countries and the people who are getting infected. Next slide. So just to give you an idea of how this relates more specifically to children, if you see that top bar on the left, about 2% of all the infected people are children in this country. And you could see, obviously, over time, these cases accumulate as we get to know it. And who are the children who get infected? If you look at those bottom blue bars, we see that between 10 and 17 are the highest rates. Younger children are not affected. And I did want to point out that the pediatric symptoms versus the adult symptoms, much less severity overall, less fever, less cough. But what they do have is more of the stomach illness that is not seen as heavily in adults. Next slide. So there was a question that was raised about this new entity that has been reported, and you've probably heard something about. It has a fancy name, multisystem inflammatory syndrome in children, but we call it MIS-C. And it does appear to be associated with children who have had an infection with the coronavirus, called COVID-19 sometimes. And It does appear to be a condition where different body parts become inflamed, and there is actually a difference in time between becoming infected, and then there's about a delay of about a month to when children actually get these symptoms. We don't know what exactly causes it, but it does appear to be in people who have shown this past infection with the coronavirus. There's been greater than 300 cases that have been reported. I list the symptoms there in case you're curious or have any questions. Of course, if your child is symptomatic at all, you should call your team at any time. The rate for this complication of the infection is about 0.002% of all children infected. Next slide, please. So how do we test for it? This was a question that came up, so I wanted to make sure I gave you an explanation of this. So one way to test is to look for the virus itself. And so we can detect this when we take a sample from your nose or from your mouth. This is done at times when people are sick or when they're actively infected with the virus, so we expect to find it around. We could look at different body parts and different fluids. This is done by something called polymerase chain reaction, or PCR. You might have heard that. And it's really looking for just parts of this virus. And when we actually detect it, we don't know if that virus is actually able to cause infection. So the viral particles can just be around, and they may actually not be having you be contagious or anything like that. So it cannot determine that. Just because it's present does not mean it's viable. The other way that we actually can test for this is detecting an immune response to the virus. So when a person is infected, they actually develop a response to it. That's called your immune response. One measurement is to look for proteins called antibodies. And we are able to look at these antibodies in response to this COVID virus. What we don't know at this time is the presence of these antibodies. We don't know if they mean that you're protected from reinfection, or if they'd be helpful if we gave them to somebody else. Next slide, please. So the update on treatment and prevention, we are still learning best treatment options. So again, this virus has not been around long enough for us to totally understand it. We have experience from the other two viruses, though, that I told you about. So we are learning more about medicines that actually we can use against the virus itself. Medicines that we can use in case your immune system is inflamed, which can happen in the more severe forms of the disease, and medicines that provide immunity against the virus. So there are some effective treatment regimens, and we have been experienced in using them at Stanford. Antibody therapy is one thing that you may have heard about, where we call it convalescent titer, where someone who's been infected and is now recovered, we take their sort of immune system and give it to somebody who's infected. The efficacy of this and the safety of this actually is controversial. Sometimes it shows that it's helpful, some beneficial, and sometimes not. So we're still learning about that. We are learning that certain ways in which we can get some of this immunity, so very specific immunity, labs are working on seeing if they can actually isolate this immunity and then give it to other people before they get infected, and would that be helpful? This may be available at the end of 2020, and immunocompromised, so like liver transplant individuals, would be the first on the list to get something like this. Next slide, please. And lastly, I just wanted to give you some vaccine updates. There's hundreds of vaccine candidates in discovery, so a lot of really great, smart people working on this. 22 are in really early phases, but 3 are actually coming to larger phase trials in mostly healthy people right now between July and September. 2 of these vaccines, if successful, may be available either at the end of 2020 or early 2021, and they would be safe for use in liver transplant patients, so stay tuned on that. However, we do not know if these vaccines will be effective in preventing disease if you're exposed to it. We just know that they actually cause you to have an immune response. Next slide. So in summary, I just wanted to point out that the virus continues to circulate. Most individuals do not have severe disease or poor outcomes. It's important to continue to minimize your exposure. as will be talked about. The shelter in place has allowed us time for a better understanding of treatment options and development of better prevention strategies. And remember that the virus has only been present for 4 months, so most is still unknown, such as effective treatments or long-term outcomes, and the preventive measures are still under investigation. So we just have to realize that it's going to be with us for a period of time. Thank you.
Now we can move on to Dr. Chen to talk a little bit more about considerations to keep in mind as we think about the prospect of returning back to work and school.
Hello to all of you. Thank you, Dr. Benson and Kat, for organizing this and inviting me to your town hall. My name is Sharon Chan. I am one of the other pediatric infectious disease physicians. And as Dr. Gans mentioned, she and I work very closely with your liver transplant team. Next slide. So my advice to you for going back to school and work is to empower you to make this decision. And I'm going to give you a framework to use, something you already know. And I'm confident that with this framework, you will make the right decision for your child, your family, and your specific circumstances. So next slide. This is the framework. And I'll just give you a bit of time to try to decipher each one of these symbols. I guarantee you that you know these. So next slide. These are specific actions that you can take to decrease your risk of infection with the coronavirus. And like I said, these are things you already know. You know how it spreads. Wash your hands to prevent transmission, avoid close contact, wear a face covering, cover your cough and sneeze and throw away that tissue immediately, clean and disinfect, and then closely monitor your health. And in your child's specific case, also think about their immune suppression level. Now, all of these actions we take as individuals to prevent transmission of the virus. And next slide, as you all know, transmission, how this virus spreads, is predominantly person to person. So it is with people in close contact to each other. So that's why we talk a lot about social distancing. It's through respiratory droplets from an infected person coughing, sneezing, talking, perhaps, and these droplets can then get to someone else. So we wear our face coverings and we contain our own secretions. Now, just like we as individuals want to decrease the risk of transmission, facilities want to also, and they use the same framework. Next slide. And so the separate facilities, that is schools or camps or childcare facilities, businesses, they take the same framework to decrease the risk of virus transmission. They convey knowledge of how the virus is spread. They promote healthy hygiene practices, washing hands, promote social distancing, intensify cleaning and disinfection, and really think about improving ventilation. And then monitor health of their specific staff, but also how to maintain a healthy operations in total. The CDC has come out with specific guidance for these particular entities. These are ones that you can read on your own, have discussions with your providers. And in the next slide, I gave you an excerpt. You can go to the next slide. This is specifically for schools under the anchor of how do you promote social distancing? I'll just read a couple out. First, ensure that the student and staff groupings are as static as possible by having the same group of children stay with the same staff. Restrict mixing between groups. Cancel field trips, inter-group events, extracurricular activities, etc. So next slide. How do you then figure this out? How do you make this decision? So using the framework that I showed you, which is things you already know, what actions, ask yourself, what actions could you take to mitigate against infection if you were to go back to work or your child goes back to school? What actions is that facility taking to mitigate against infection? What's your comfort level with those mitigations in place? And importantly, what are the benefits for your child, your family, your special circumstance for going back to school and work? And you weigh those risks and benefits. And I encourage you to have a discussion not only with your family, but also with your provider to come up with this particular decision that's the right decision for you and your family and your child. So Kat had shared some specific questions, and I thought I'd go through a couple of those as examples of how to use this framework. I believe one of them was about a child who, or young adult who was going to go back to college. And if this child was going to go back to college, should this family ask for a single dorm room? If you go back to the framework and think about the part about social distancing, you can think about that decision with leaning towards, yes, it would be a good idea to have a single room, because that is a good way of really keeping distance from other people and mitigating against transmission. There were other questions about parents having to go back to work and worried about going back to work with a child at home who's received a liver transplant. And again, I would say that go back to the framework and think about ways that as an individual, how can you mitigate against infection? That is, what things can you do upon coming home, washing hands, cleaning high touch areas, etc. And then also asking, what are the facilities doing to decrease virus transmission and protect you as an employee? What is their cleaning regimen? What is their disinfection regimen? What is their increasing ventilation regimen? What kinds of protective equipment are they providing? Are they employing social distancing in terms of customers and even the staff? And with those in mind, then weighing those risks and benefits and then coming up with your decision. So I hope that this allows you to use a framework and it empowers you to help make these decisions that will be the right decisions for you and your family. Thank you.
Thank you, Sharon, for addressing that really difficult question that I think is on all of our minds. And just want to remind all of our families too that we are here to help support those decisions. And if you need documentation for school or letters or other ways to help navigate that, we're, as always, are here to help with that. I want to pass on next to Dr. Ebel. We're amazingly lucky that Dr. Ebel has been one of the leaders working with folks all around the country and gathering more data on what is happening with COVID in kids with chronic liver disease and kids with liver transplant. And I know that's on many of your minds, and had a question in the chat as well already. So I will leave it to her to tell you a little more about what do we know so far and how are we gathering that information.
Thank you. Kat, next slide, please. So I wanted to talk about our COVID registry and narrow it even further from thinking about like general pediatric patients related to COVID and shrink it really down and small to our community of liver transplant pediatric recipients. So we started this registry, and it was an effort, as Dr. Bensen said, led by Stanford and Columbia, and then two of our colleagues, Toronto and Queens in Canada, to create this international registry that's primarily North American data to just try to capture patients that have pediatric liver transplant patients that became COVID positive. We partnered to just sort of have this expansive reach and pull in this data with SPLIT, the Society of Pediatric Liver Transplantation, and then also NASP again, which is our sort of national US group related, it's a GI society. We're now in week 10 of reporting data, and so some of my slides will reflect that. And then this includes not only children who have chronic liver disease or sort of pre-transplant, but also those who are post-liver transplant. So that's what I'm going to talk about more is like your children who have had a liver transplant, what the data has shown us. Next slide, please. So there's 20 children who are essentially pre-transplant or with chronic liver disease, 21 who have had a liver transplant. So I'm really going to focus on those 21 children. Next slide, please. The numbers, as I mentioned, might feel really small. We didn't worry about that, but we wanted to make sure that we were actually capturing all these patients. And so we've reached out to our society is actually pretty small, our community is small of pediatric liver doctors and infectious disease specialists. So we sort of reached out to all the centers just to make sure that we're capturing all those patients. And from the centers we've reached out to, they say we absolutely used your registry. We had one patient, we made sure we submitted that. So the number is small, but we think it's actually capturing a good cross section of this population. I wanted to start by alleviating maybe a worry that you as a family have thought about, that we have not heard of any deaths of any child or young adult who's had a liver transplant. That has not been reported to our registry, but we've not heard that in our community. Next slide, please. For the data, about half are male. The ages range from 6 months to 21 years old. And then 40% of the children who were COVID positive after their transplant, their indication for transplant was biliary atresia, and 25% of them had acute liver failure. I had a question in the chat that I wanted to address, is that we do also include patients with intestinal transplant. So we have 2 patients in our registry. They both happen to be patients who were multivisceral transplants, who had a liver transplant and an intestinal transplant. But we also have the Intestinal Transplant Society is also part of this registry. And yes, we do include those patients. Next slide, please. What Dr. Gans was talking about was what are the presenting symptoms, and we wanted to capture that too for pediatric liver transplant and intestinal transplant recipients to see if it felt any different. But this is sort of what folks have shown us, and it can be multiple. So a family could have, or a patient could have had respiratory illness and also GI symptoms like diarrhea, but just to sort of sort them out. And when we talk about constitutional, we're really saying things like fever or loss of smell and taste or muscle aches or sore throat was what we sort of captured for that. It feels about the same though what we're seeing in pediatric patients in general. Next slide, please. We wanted to know, and some families had this question that I'll get to in the end, sort of, can you stratify the risk of my child, or how immunocompromised were these patients that developed COVID? So we wanted to ask that question up front. At the time of your COVID diagnosis, what immunosuppression were these patients on? So they were on multiple agents, as we all know, for our patients too. So the majority were on tacrolimus as their sort of primary immunosuppression, and then there was layers added to that for some patients. So for example, they were on tacrolimus plus Cellcept plus steroids. But this was sort of overall what patients were on at the time that they were diagnosed. Next slide. And then we wanted to know what changes. So the purpose of this registry was to give a way to give this real-time data, not only to medical providers, but also to families. And in the end, I'll give you the link, and we'll send these slides out too. We'll give you the link that you can see this. Every week we update it. So this is a way for our community to say, okay, your liver transplant or intestinal transplant patient is COVID positive. What are you doing to help them clear this infection? So 8 out of 20 of the patients decreased a dose of their immunosuppressive medication. So for example, they lowered the tacrolimus trough from 6 to 8 down to 4 to 6. 5 out of 20 patients stopped in immunosuppressive medication. So for example, temporarily held Cellcept or did that to minimize immunosuppression to help these patients recover faster. And 50% made no changes to their immunosuppression. Next slide. So that no child has required ventilatory support, and you may have heard that in the media or thinking about adults or children as well, but no child with a liver or intestinal transplant has required a breathing tube. Next slide. 70% of children were able to remain at home for the duration of their illness with COVID. 15% came into the hospital but stayed on the sort of general ward or the floor, and 15% were admitted to the intensive care unit for some more intensive monitoring, but again, none required a ventilator. Next slide. And then this was a question I was referring to, a great question from a parent that may be on others' minds as well. So the question was, is there a difference in the disease course depending on how far out my child is from their transplant and how immunosuppressed they are due to their anti-rejection medication dose, which is a really elegant question. And we run into this a lot with registry data, or when you're thinking about research and you're saying, based on these 20 patients that we know about in North America and a couple from outside countries outside of North America, can we answer that question with just 20 patients? We can't confidently answer it, but I wanted to answer it in a reverse way. So we do know from one of the most complex cases that we have heard about was a baby that was the recipient of a living donor transplant, who we believe, from what we know, was COVID positive at the time of that transplant. The child subsequently became, or the recipient of that liver transplant subsequently became COVID positive. So now you're thinking of a scenario where the child is the closest they can be out from liver transplants, or the most immunosuppressed they'll be during the course of their transplant, and that child had a very good outcome and is doing well. So I think that's a reverse way of answering the question from the little we know of the 20 patients that we've seen, that even in those sort of worst case scenarios, some families like to know that what ended up happening to that patient. But I'm sorry, I don't have a directed answer to that exact question, but I think that's a really elegant question. Next slide, please. So in summary, no child with a liver transplant or intestinal transplant with COVID has died. The majority of children in our registry didn't require being admitted to the hospital. Stanford, to help continue to hopefully alleviate the burden for some of our families, is leading this national and international effort to learn more about COVID. So as we know more, we will help disseminate that information to our transplant families and to other centers as well. Next slide. And then we'll send this out, but essentially, if you just want to remember something to Google, if you put split and COVID, you'll come up with this website, but we post that once a week, and that data is available publicly to anybody who wants to look at it. Next slide. And this was just a plug to stay tuned. That engagement with our families as partners is really important to our team, and we have a few other ideas in the pipeline, so we'll be in touch about those things soon. But thank you for the opportunity to talk about our registry.
Thank you, Noelle. That was wonderful. I think before I move on to this next topic very quickly, just wanted to answer one of the questions that had come up in the chat, which I think is a very common question of, is it worth it to get antibody testing to know if we've had COVID before? And I think that's one where I think if we're trying to identify whether or not someone has had it, I think it's helpful sometimes in the setting of having a clear exposure and knowing that we've had symptoms or exposure to have an answer to that. But since we're still trying to understand what does that exposure mean for future immunity, we need to be very careful with kind of how do we interpret those results. So as Dr. Gans mentioned, we have antibody testing available, but we still don't know what have confirmation of the immunity provided by the antibody testing, or of how long that immunity might last. So I think it depends how important it is to know if we've been exposed yet, or thinking about what that means for your family. But at the same time, we still need to take ongoing precautions for social distancing, et cetera. On to our next very, very brief topic, which is medications in the time of COVID. And really the short answer to that is thinking about our transplant medicines. In the absence of infection, we stay on our regular transplant medicines. We recommend keeping our immunosuppression the same. We don't make changes in anticipation of potential infection. What we want to do is, in fact, now even more than ever, is try to prevent rejection, keep things going smoothly so that we don't run into any more difficulties than we need to in this era of COVID. And then I will move on to Rachel, talking about, again, how are we managing here in clinic?
So we wanted to, can you hear me? Sure. Yeah, okay, good. We wanted to discuss the steps we're taking at Packard to protect our patients and reassure families that it is safe to continue getting care. So we're continuing to see patients via telehealth to your home. And we think that's a really good option for our stable patients who just need their routine follow-up. For patients with recent transplants or complicated courses or questions, we are seeing patients in person in our clinic. So there are screeners at the door before you can get into clinic, and they're screening everyone prior to entering the building. They are also ensuring that patients and providers are wearing masks and making sure that everyone can practice social distancing. So we also want to encourage our patients that it's safe to get labs, and we want you to continue getting labs as directed by your coordinator at the appropriate time interval. And in speaking with patients who are getting labs at outside hospitals or Quest or LabCorp, it sounds like in general there are appropriate infection prevention measures being taken there. But if you go somewhere, of course, and it seems too crowded or someone's coughing, you can always leave and come to Packard if you're close enough, or go to a different location or try a different time of day. If your child needs to go into the hospital for an admission or procedure, the hospital is also taking all those recommended steps, including screening, physical distancing, masks for patients, providers, and caregivers, and cleaning. And then just as a reminder, there are limitations on visitors for patients in the hospital and in clinic. And in general, siblings aren't allowed to attend. And then if you're concerned that you have symptoms of COVID, we don't want you to come to clinic, so call us and we can discuss how to proceed. That's all.
And now we can move on to Denise, talking about stress management, coping, and resources in this unsettling time.
Sorry, I was muted. Hi, everyone. Amy and I put together a little list for you all of some skills that we thought might be helpful to parent during a pandemic. So now that we're all so stressed about COVID and keeping ourselves safe, I wanted to just talk through some of these in no particular order. So the first one is coping skills. So I know it's really tempting to fall back on our unhealthy coping mechanisms, but we encourage you to try and make choices and do things that will make you feel better physically and emotionally. Things like exercise and listening to music, watching movies, talking to your best friend, coloring, journaling, meditation, those sort of things. Sometimes just taking a parent timeout can do wonders for your own mental health. Highly recommend that one. Number 2 is support. So your support network probably looks really different right now, and they're still there for you. So reach out to your family, your friends, your religious and spiritual leaders, your school communities. There are also some really great telehealth options for therapy, and you don't even need to get out of your sweatpants to go to therapy anymore. So let us know if you're interested. Number 3 is creativity. So use your imagination and your child's imagination to find some new things to keep boredom away. You know, let your kids come up with a plan for the day. Let them kind of direct what you guys are going to do. You can make pillow forts. You can have slumber parties in other parts of the house. Camp in the backyard. You know, get out the chalk, make a mural on the driveway. Kids have such creative ideas that it's really fun to see what they come up with. Number 4, education. So remember when you guys were researching online to learn all the things about transplant, and we cautioned you about reading things online that aren't specific to your child? Same rules apply during a pandemic. So the CDC has a really great website with up-to-date information. There's lots of legitimate news sources to access information, and you can always talk to us, your transplant team, and we'll tell you what we know. Number 5, patience and grace. So practice patience and grace with yourself, with your spouse, with your kids, your family, your friends, your healthcare providers, your annoying neighbors. everybody is struggling right now, and everyone needs a dose of kindness and compassion, specifically yourself. Being a parent during a pandemic is really hard, and the guidebook on how to do this hasn't been written yet. So just do your best with being patient with yourself. Number 6, flexibility. So having flexibility means being able to shift perspectives and kind of adjust your actions based on the information in front of you. So I think you'd agree, information about COVID changes pretty frequently, and we're constantly adapting to the recommendations of health officials to keep us all safe. So evidence shows, though, that being flexible can reduce feelings of anxiety and depression. And so think of it as protection for your mental health when you decide to focus on positives of your situation rather than dwell on all the bad things. I mean, I get it, this is hard. And there are a lot of negatives right now, but I challenge you to think of one positive thing that's happening right now, and then try and focus on that for a few minutes each day and just see what happens. Number 7, a sense of humor, because it is scientifically proven that laughter decreases stress hormones and increases immune cells and infection-fighting antibodies. It also triggers release of endorphins, body's feel-good chemicals. So now you have permission to go look up some good memes, watch some silly puppy videos, tell each other really bad jokes. Laughter is a really good thing right now. Number 8, a break from social media. So pay attention to what you and your kids see on TV, hear on the radio, or watch online. Maybe consider reducing the amount of screen time focused on COVID. Talk to your kids about how sometimes things online are based on rumors and incorrect information, and encourage them to bring their questions to you. And so that way you can have a good, honest conversation with them. Something I've found really helpful is deleting my apps off my phone and taking long breaks from social media. I feel like this has reduced my own feelings of anxiety. Something you can try. Number 9, permission to grieve. So this discomfort we're all feeling right now is uncertainty and grief. The loss of normalcy, loss of our connections, our daily routines. We miss our families, we miss our friends, our schools, all the milestones we couldn't celebrate. These are all things we and our children are grieving right now. So parents and caregivers, you play a really important role in helping children process their grief. Talk about how you're feeling. Make it okay for your kids to share how they're feeling too. There's so much loss right now, it can feel very overwhelming. So reach out to your support network, use all the skills we just talked about. Hopefully these things can help you manage your own feelings and give your kids a safe space to kind of talk about their big feelings too. And then last is resources. So financial resources, parenting support, mental health resources. There's kind of a lot of stuff out there. So Amy and I put together a list of some of our favorite online resources with some links, and that'll be kind of at the end of this slideshow. But also know that Amy and I are available for any needs that might be specific to your family and your situation. So reach out, let us know how we can help. We're definitely here for you. Kat, next slide. Just kind of slide through. These are just some like stress management and coping type of slides and things to peruse in all of your spare time. Go ahead, next. Some stuff that we talked about already. Next. And these next 2 are phone numbers and links for resources and things for mental health support. And next. And some support groups. Thank you.
Kat, do you think I could swing back and answer some more specifics about the antibodies, because there does seem to be a few questions about that?
That would be wonderful, Hayley.
Okay, great. So I know that everyone's very interested in understanding if they've been exposed to the disease and if there's a possibility that if they are exposed and then recover, does that mean that their risk moving forward is different than other people? And one way to do that, obviously, as we've talked about, is to say, oh, I do have antibodies to this, so obviously I was exposed, and what does that mean? I just wanted to reiterate what Dr. Bensen had also mentioned, is that, again, we still don't understand what those antibodies mean. Antibodies are not the body's way in which it clears a virus. So they're not thought to be specific to helping you recover from a viral illness. So they are a way that we have easy access to the blood. We can show that you have antibodies. They're only part of your immune response. And so we don't understand specifically for this respiratory virus what those antibodies mean and how they protect you. There are some data that is coming out of the lab now to show that, yes, they might be able to prevent the virus from actually infecting cells. So maybe if you get exposed and you have antibodies there, they could potentially prevent the virus from getting inside your cells. That part of it, we haven't tested in people. And so while you can go and get the test, it's available. And please make sure you realize also that not all antibody tests are equal. We have a good antibody test here at Stanford. We've tested it on infected people. And in our actual antibody test, all of our infected people will develop antibody responses by about day 21. But that is not the case in all antibody tests. So you might get them, and we don't really know if they show up negative, if that's actually a true negative, because they don't all perform the same way. So just understanding that as well. But again, they're available, you can go get them. What we don't want you to do is say, okay, I have had the disease, I have this marker that shows that I've had the disease and now I am protected, because we don't understand that. So unfortunately, we will have to wait another sort of round of infections to even start understanding some of the, what we call protective immunity.
Thank you, Hayley. That's really helpful. Do you have any thoughts about the risk versus benefit of receiving routine dental care?
So I think that, and as I think Rachel stressed, most of healthcare institutions, so I will include dental with that, have really taken above and beyond precautions in order to make sure that their environments are safe for people to come in. There's also been extensive testing of most healthcare workers, so we're extensively tested at Stanford. So there's not a lot of people who are infected who are caring for your children, or should be zero and everyone is masked. So I do think that that scenario is not a high risk for your child, and obviously routine dental care is important for their health. So I think among all the things that we can go and do as we risk stratify our activities, that's a very low risk activity.
And on the topic of health maintenance, I think there's also been around the country kind of lower rates of folks receiving vaccines because of not going for routine checkups or because of pediatrician offices being closed. And also want to support that routine vaccines, the same vaccines that we generally recommend for your child. Again, with the caveat that those are a little different for your children than for the general population. But we still recommend now, at perhaps even more than we do across the board, because of the lower rates potentially in the community, putting those diseases back out there. So we do recommend going to the pediatrician for checkups and for getting routine vaccines as you would otherwise.
And if I may add to that, very important, please go and have your routine health maintenance, because you don't want to become sick with any of those and then have healthcare providers not understand what you have. Please get your flu vaccine this year. This is going to be a particularly important year for everyone in your family and anyone that you know or comes in great contact with you to get flu vaccines, so that illnesses that look like flu or COVID can be distinguished from each other. Well, the illnesses won't, but at least you'll be protected from one of the two.
There was another question about sports. I think sports are challenging in that most sports involve contact with either, a shared ball or another person. So again, thinking about sports and the structure of social distancing. So, cross-country track, other things ways where you can keep people separate from each other are safer. Sports that bring a lot of kids close together and exposed to each other, breathing on each other very closely, especially as you're out of breath and running, are more of a challenge.
The only thing I would add to that is that it's very important to make sure you continue to exercise. I realize that exactly as Dr. Bensen said, some contact sports and some sports where you're close or sharing equipment are probably not a good idea, but it's a really good idea to keep yourself active and healthy. And being outside is a wonderful open thing to do where you can usually distance yourself.
Yeah, for your physical and your mental health. Yeah. Well, just wanted to wrap up by thanking all of you for joining us and giving us a little bit of your precious time so that we could talk with you. Please send us messages and let us know if this was helpful for you, if there's something that you'd like us to do in the future, if there's ways that we can continue to communicate with you as we're continuing to work on different formats about how we can stay connected, especially at this time when we are together in person less than we normally would, and where we unfortunately had to cancel some of those things that we all look forward to, like picnic or camp or other things like that. So please just share with us what we can do to stay connected, and we were really happy to have you join us today. And thank you to all of our panelists, especially our ID colleagues, Dr. Gans and Dr. Chen, for joining us to help share their expertise.
It was great to be here. Thank you. Have a good evening, everyone.